So hello, everyone. Well, it's my pleasure to be here with you all in person or virtually. So this is the last talk. So, okay, hang in there, the last one. So today I'm going to talk about how to conduct human intracranial research. And so I was inspired by Stephanie Reyes and her talk. So I decided to start to explain you a bit my career path. So it actually started here in Marseille. I did my PhD here in language. So I work on picture naming, and I use EEG and IEG. And then I did a couple of months in Cleveland at the very end of my PhD with Patrick Chauvel and Catherine Chauvel. So I worked also a bit in IEG in Cleveland. Then I came back to Marseille, and I actually did 8 months in Australia, where I worked in linguistic process using TDCS. That was the only time I didn't work with EEG or IEG. But I still met many people working in IEG because they were trained by people in Cleveland. So, you know, it's a small world. Everyone knows each other. And then I started a postdoc in Oslo in the very first IEG lab in Scandinavia. And I worked 3 years there. Sorry. And I was in collaboration with Bob Knight at UC Berkeley at this time. And so I went to visit his lab, and I ended up staying there. And now I'm there for 3 years. So I'm not a postdoc anymore. I'm a researcher in his team. And all these H that you can see are actually all the hospital sites that we record IEG from. So we have a lot of sites in California, in SoCal, and also like Irvine or San Diego, and also, of course, all around the Bay, San Francisco Bay. And we have patients in Albany and also in New York. So, yep, I did a bunch of IEG all around the world, and I'm really grateful for that. So first things first, today, I'm going to talk to you about many things, but mostly my goal is to show you kind of the ugly or the backstage of doing IEG research, because I know it's really trendy. Many of you might be interested in, starting to work in that field because it's a really exciting one. But it's also really challenging, and I think not everyone knows what's behind these fancy results. So this is a bit what I'm going to show you today. So first things first, IEG in clinics, because as you might all know, we can't put electrodes inside a healthy brain yet. But so IEG is mostly used in the treatment of drug-resistant epilepsy. And so actually epilepsy is a pretty common disease. So we have like around 1% of the world population with epilepsy, and 30% of them have drug-resistant epilepsy, which means that they keep seizing despite medication. And so some of them are candidates for surgery to remove, the epilepsy focus or some part of the brain network, epileptic brain network. And so this is a bit what happened when these patients came at the hospital. The first thing is they will have the phase 1, which consists of a classic EEG, well, not a cap one, right? They will just glue EEG on their head, and the patient will stay at the hospital for like a week or so. They will be monitored 24/7, and they will remove medication and let the patient seize and try to see where the epilepsy is from. And then the second phase is the one that we are interested in, will be when they implant electrodes inside the brain, of course, based on the clinician's assumption of the epilepsy onset, which means that, as scientists, we don't have our word about where the electrodes will be. And the patient will stay between usually 1 week, 3 weeks is really rare, but it happens, because the aim is actually to try to record 3 type of like canonical seizures, and then to remove the electrodes. And then there will be a meeting with the clinical staff, and they will decide if this patient can have a surgery or not. And so IEG is actually a really interesting tool also for scientists, because it has a really unique spatiotemporal resolution of like milliseconds and millimeter. So you can really see specific part of the brain with a really nice, actually, temporal dynamics. So it's pretty cool. It's really unique. So you can somehow look at the brain online. And so I'm pretty sure you all know, but we have two main methods of IEG, the stereo EEG, SEEG1, called SEEG, and the electrocorticography, ECOG. So the SEEG is actually a French technique, has been developed in Paris in the late 50s by Banco and Talerac. And the ECOG, I think it's American, I'm not even sure. But so the main difference is actually, well, the electrodes. So the SEEG consists on like a really long platinum electrodes that will be implanted directly in the patient's brain. So it's 1 millimeter of diameter, and the distance between all these gray things that you can see here, which are called contacts, are really different according to the hospital or the ones you're using. They can be between 2 and 10 millimeters distance apart. And sometimes they get closer when they're like in the more medial part of the brain. So it depends on the electrodes you have. And the ECOGs are more like a grid of electrodes that we just like put directly, on top of the brains of patients. And sometimes you can have what they call strip, which is just like one line of electrode that would be just like slides through some sulcus. And so it's also platinum electrodes, and with a silicon membrane of 0.5 millimeter, it's 4 millimeter diameter, and it's 10 millimeters, or sometimes now way less between contacts. And so the difference between these two is also what they record, right? So the HCEG is really good for depth structures and localization because you can go all the way to, for instance, hippocampus. But it has a kind of poor samplings because, you will have like somehow 10 electrodes per patient, but, they can sometimes be really like far away from each other. So it's the poor sampling of SEEG. And the ECOG has a good sampling of neighboring regions because you can see what happened, in like one specific brain areas, but you don't have access to the depth brain structures. And also, for instance, 10 years ago in the US, most of the people will use ECOG, and nowadays it's 80% SEEG and 20% ECOG. So there is a real shift. Like now, SEEG is way more common than ECOG, actually. And if you look at the IEG in research, well, you can see that there are more and more interest in using IEG in research, and especially in cognition. And so you can see the two different techniques, the SEEG and the ECOG, and these are like SEEG electrodes contact in the hippocampus. So it's becoming trendy to do IEG. And so IEG is good to record different type of things and, to look at the brain in different ways. So for instance, we can look at what's called local field potential, which are like brain ERPs, like, inside ERPs. And so for instance, you can do some single trial analysis, and this is a paper by Anne-Sophie, actually. She looked at the difference between SEEG, EEG, and MEG. But for like sake of simplicity, I just show you SEEG and EEG. And so you can see the ERPs during a reversing checkerboard. And you can see the difference of what the SEEG is providing you as information and the EEG. So for instance, this one is common for both, but you can see more information in the SEEG than in the EEG. So it's different. And this one is the paper I did during my PhD, where you can actually, it's in a picture naming, but the thing I wanted to show you is really that with SEEG, you can also see the specificity of some brain regions. For instance, these two first contacts are inside the hippocampus, and the three others are right outside the hippocampus, 2 millimeters outside of the hippocampus. And you can clearly see that the signal is really different. So you can have like specific activity inside some specific brain structures. And so the hippocampus is an interesting, I think, brain region for that, because what happened in the hippocampus stays in the hippocampus from what you can see. There is no kind of like spread of activity outside of the hippocampus. Another type of analysis that you can do with IEG is, of course, frequency analysis. And there is one thing that's really specific of IEG is the high frequency broadband analysis because we have access to high gamma, which is above 70 hertz to like 150 hertz. And it's really specific to IEG. And now it's known to reflect the activity of a group of neurons firing together in sync, which is somehow maybe the closest to the Bolt signal, except that it's not delayed on time. So it's something that people looked at a lot. This high gamma is something really popular in science right now. And here again, if you look at, for instance, at the difference between time frequency in EEG and SEEG, you can really see that the SEEG will pick up on this huge blob of high gamma that the EEG will actually miss. So that's also a big advantage of IEG. And I also wanted to show you another cool paper from Vidal, which look at the high gamma, the alpha and beta, and the IERP, like local field potential I showed you, and in the fusiform gyrus, and you can really see the specificity of the phase stimuli in these brain regions, and you can see it in like with different tools, and so you can see it in, of course, in the broadband, and you can also see some difference, maybe less clear, but still in the alpha and beta, and the ERPs is really different too. So, and it's also single trial, which I think is pretty cool. Of course, connectivity is something that is often, used in IEG. So this is just an example of a successful item recall in a paper from Solomon, and you can see the connectivity. This is a phase locking value in theta and in high gamma with synchronous and asynchronous connectivity between different brain regions, which I think is pretty cool. And the last thing that's also is really trendy in IEG is to do some decoding models. And just to show you one from Eddie Cheng's group, where they decode this, they decode the speech based on ECOG implanted in like the motors area, and then it will be able to reconstruct the speech, emanated from this ECOG. So it's actually really cool, and I think this had a lot of like nice implementation and a nice future ahead. So that said, so you have all these fancy things that you can do, and that's all the things that you usually see when we talk about IEG. But what I really want to talk to you about today is actually what happened before having all this like nice data. So what happened before recording, during recording, and after recording. So all these things that usually you don't really see in papers. So before recording, the first thing is how to design a task for IEG. And you have a lot of things to take into account, right? So the setup is really different than normal EEG. Usually you have like, it's a bedside study because, you work, most of the hospital will work, directly in the patient's bedrooms. You have a short time window, right? So you can't just like spend 5 hours with the patients. You can come in, sometimes the patient will have like, 30 minutes with you. So you have to like think about all these things when you are designing a task. And also, of course, there is this risk of seizure. So, the brain might change also really quickly. The activity will change. There is drug removal. A lot of things happen. So you have to think about all these things when you design a task. But on the other end, you also have an exceptional signal-to-noise ratio because you are inside the brain. So this is also a good advantage that you can take, from the IEG. And so usually what we try to do is to have a shorter tasks than the one we usually use in EEG. This is just an example of a task I'm running right now in language prediction, and I have 84 trials. That's it, 42 per conditions. It's a 12 minutes long task. It's really short, but now I'm sure that actually all the hospitals can do it. And, sometimes the patient will be like, oh, I'm tired, I just want to do a quick things, and then, can you go? And then they will do my task. So I actually end up having more data than if you have like an hour-long task. So yeah, it's things that you have to think about. Of course, we try to test our task also in EEG first, right? To make sure that this works properly, that you have the marker you're looking for, all these type of things, before moving on to the SEEG. But it's usually something we try to do, have shorter task. There is also something else before recording, which is the access to patients. Actually, it's not that easy to you can't knock at, epilepsy door and be like, hey, do you want to hang out and do some tasks with me? So it's a lot of work. And so you work in a clinical settings, you work with clinicians, you have to have, ERBs, you have to getting fundings with clinicians, you have to have ethical approval. It's pretty tricky. And also, there is a big question that comes often when we work with patients, and I'm pretty sure most of you know about it, is the consent form. It's a question that we have a lot. We have a lot of meetings about that. We also have like meetings with people in like ethical groups, like who and how to ask for consent. Because, there are a lot of power, at play when you work with patients. And so if the clinician is asking, or should like, at least researchers should be, with the clinician when the clinician is asking about, consenting and things like that. It's a lot of questions. And to be honest with you, I think that in most of the places I've been, the clinician asks for consent, but sometimes they ask also for scientists to be there. Sometimes they don't. So it really depends also on the hospital policy. So it's not something that's all the time the same. And then the last things about like before recording is to get ready to record, because you have a short time window, so you have to arrive prepared. You have to know the task, the instructions, you have to know a lot of things. And so usually what we do is we will receive the schematic implantation of the case beforehand. And so we will, kind of like do the list of the tasks that we will prioritize according to the implantation, right? So if we have, implantation in LIFG, then we will do more language tasks. If we have like more motor implantation, we'll do like more motor tasks. So it depends on the implantation. We will just like guide the list of tasks that we hope doing with the patient. And then we will review the instructions, the material needed, because sometimes, especially in Bob's lab, we have to fly to another place in California. So you want to make sure that you have all the materials with you that you will need to test the patient, because you can't just run back to your office and, grab what's missing. But it depends too. Like for instance, in Oslo or in Marseille, I was at like 5 minutes from the hospital. So, it was less complicated. So, but all the things you need to think about. And then, during recording, this is when, the fun happens. You at the hospital, right? And I think the key words during recording is really unpredictability. You with patients in a settings, and sometimes you can have several patients in one bedrooms. So, then it means that nurse will come in to talk with the other patients, clinician will come in. You also have to deal with family. Sometimes some family don't want the patients to do the task, even though the patient wants. So you also sometimes have to ask the family to, get out of the room, because, you want the patients to be focused on the task. And then, the risk of seizure. So you need to recognize seizures on the screen, because you need to be really proactive, because the patients will have a laptop on his lap. And if something happened, you need, to make sure that the patient is safe, that the material, can be safe. And also your other colleagues and things like that. So it's actually a lot to think about. And that said, the other things that are also really challenging are the recording systems, because different hospitals have different settings, different systems of recording, and sometimes even in one hospital, they can change, like between 1 month to another. And so you also have to be prepared to know how to like plug your system, how to record the signal, how to like, plug your photodiodes, and to know how to collect the data, to know where to look at your data, to know if, the frequency sampling is good, and all this type of things. So it's also a lot of things that you need to know before getting into a room, because you are with a patient, so you want to look professional. And then once all these things are done and you're happy with the data, the few data you managed to record, you have also a lot of things to do to grab your data. The first thing is to make sure that there is no way for anyone to know who the patient is. So you have to make sure that the data you will have are actually anonymized. And then there is a fun part of the data extraction and transfer, because different settings and systems mean different formats according to the system. And so we can have a lot of different formats. So you have a lot of different cases. And so it means that loading the data on field trip or anywhere else, it's not that easy. because then, you know, you also want to look at the population of patients. So you need to find a way to somehow make them in the same, you know, system and template to be able to work with them. And it's really challenging. And sometimes you will have some data missing and things like that. So it's not that easy. And for instance, something that starts to happen quite often is the fact that we need to merge and align the clinical recording and the research recording, because sometimes, for instance, when we use single unit, we'll have too many channels to actually have everything, you know, on the research, for instance, settings, because we also need our triggers and things like that. So we need to also add channels. So sometimes we have some data on the clinical recording and some data on the research recording. So two different systems and two different computers. And we need to align them to find the triggers to make sure that we have all the data. And it's really challenging too, because we can also have different timestamp. Sometimes they have different frequency sampling. So it's a lot, right, even before like digging into the analysis. All these things takes time and it's really hard. And so that's why it's also nice to work in teams, because we all have the same issue, because we all work with the same patients. So usually, you know, each time we have new data, someone will start struggling. And so we will all help, because we know that we will all need at some point to open this data. So yeah, but it's really tricky. But so when all these things are done, you can finally start the preprocessing. And so in my lab, we use field trip to preprocess the data, and we use a toolbox made by Arjen Stolk. And so you need to do two things in parallel to preprocess intracranial recordings. You have to look at the anatomical data, and you need to look at the functional data, because then you need to, you know, like put your functional data in the brain where things happen. And so to start with the anatomical preprocessing, the first thing is what we call the co-registration. And you have many ways of doing it. In our lab, we use FreeSurfer, but there is also this eye electrodes by Alejandro Blankman. And so the thing is, you need to have like some CT and MR, sometimes pre-implantation and post-implantation. And so you have to align them, because you need to know where the electrodes are in the brain. So it's really tricky, especially with ECOG, because ECOG tend to move once you actually put the skull back on. And so a lot of pressure, and sometimes they move. So it's really hard actually to know where the electrodes are. And in ICG, which can be sometimes really tricky, is, you know, see if you have a lot of electrodes really close next to each other, it's really hard to know the label, which one is which, to make sure that you're not mixing them up. Because some sites have meaningful labels, like for instance, you know, I don't know, I think here at Lachimon is like B is like hippocampus. So you end up knowing, but when you work with different hospitals, sometimes you have no clue. You have like X, Y, Z, and you need to know where they're in the brain. And so that can be also really challenging. And then when you co-registered and you know where the electrodes are supposed to be, you also need actually to have a electrode localization, right? So you need to know now to label each regions. And so usually we do that in with SEG more than ECOG data. And so there are a lot of like softwares, automatic softwares that you can use. And they sometimes works, but the issue is if you have a lesion or like a brain a bit different than the normal one, usually the software gets lost, and sometimes they will tell you like things completely like, you know, out of reality. So it's always good to look at the localization with clinician. And so, for instance, in my lab, Bob is the thing that he loves to do the most. So we just sit down with him, take one afternoon and go through like 10 cases and just like, you know, go through like each contact to make sure where they are and things like that. And usually if you find results in one specific area, you will have to do it again in a more fine-grained, you know, like anatomical localization for one specific brain region. So all these things actually take a lot of time. And in the meantime, you also need to preprocess your data, right? And so some steps are really classical, you know, they really look like the EEG ones, but some are really different. And for instance, it's the case of the artifact removal, because, for instance, these are like SEG data. And I just took a really a subsample of some data in like amygdala. I think it's the head of hippocampus, tail of hippocampus on the right hemisphere, same thing on the left. And so you can see this signal, and I'm pretty sure you've noticed that some patterns don't look really, I don't know, usual. And so, for instance, these ones are really typical spike waves. So they're really marker of epileptic activity during enterectal periods, right? So this is not a seizure. this is just a regular brain activity for epileptic patients. But this actually means that these electrodes are involved in the epileptic network, and so they're not like healthy signal. So you should remove that too. And it's also something that we do usually with clinicians. We'll go through the data, we'll look at where the epilepsy actually kind of like starts, and we will remove the couple of electrodes that are the closest to the epileptic onset. And of course, sometimes, you don't have like only these areas, but as you can see, we have like other brain regions that are also like, involved because you have this spread out of epileptic activity. And so then it depends on the people, to be honest with you. Some will just remove this electrode and some will remove chunks of data where there are too many artifacts. But it also depends on the number of trials you have and everything, because for instance, if I start doing that, I think I might end up with 2 trials. So it depends, on what you want to do. And the other thing that also is really specific to IEEG is the rereferencing. Because so when you have the data, at first, they have this external reference, which also depends on the labs. In Marseille, usually we had like a needle stuck in the skull, which is actually a really nice reference. Some lab will use a kind of a sum of EEG electrodes on the front of the forehead of some patients. Sometimes they will use the more distal contact, so the one stuck in the skull or like outside of the brain as a reference. But so then when we reference the data, usually we don't use a common average reference, because especially for the SEEG ones, because you're in different part of the brain. And as I showed you earlier, for instance, with the hippocampus, it's kind of weird to sum all the activity of different brain regions and just like to remove it from all the brain regions. It's kind of like, physiologically, I have an issue with that. And so many people will actually use this bipolar referencing, which is you just subtract the activity from 2 adjacent contacts. And this is something you can see here. This is the the original referencing, and this is the bipolar montage. And if you look at these 2, for instance, B8 and B9, you can see that when you remove the activity, then you will only see the difference between these 2. So this is something really commonly used in my field. And the last challenge is, of course, the group level analysis, right? And so, because with one patient, you have this sampling of what's going on, but it is the only thing you can see. And so having several patients will kind of like, help you to have a clear idea of actually what's going on. And this is not easy because you need a lot of patients, and it's hard to get that many patients. And then you do this projection of MNI brain, because then you will use one brain with all of your electrodes inside. So for instance, this is a population I'm working on right now for a working memory task. And I have 11 patients collected in different places in the world with different systems, all these things. And then we have like different implantation. For instance, I have 4 bilateral implantation. And I already know that they're from Irvine, because Irvine loves doing bilateral implantation because it's robotically assisted. And so most of the time, they end up with exactly the same implantation between patients, which from a clinician point of view, it's, I think, an interesting choice, because it's not really specific to like the patients, it's always the same thing. But for researcher, it's actually really nice because we always have the electrodes in the same brain areas. So it's actually really useful for us. And then we have like patients, for instance, the yellow one are only electrode in the left hemisphere. So it really depends. But at the end, only with 11 patients, I end up with more than 1,100 clean electrodes. When I mean clean, it means without epileptic artifact. So it's already pretty cool. And the other things regarding the signal, so now it was the anatomical, but now the signal, is of course how to homogenize the data, right? Because different sites, different things, so you have different frequency sampling. Also, the type of triggers can be different. So in some places, you have this kind of like TTL triggers with like numbers and things like that. And then for other places, for instance, in the US, we use a photodiode. So you use this, like this, you always have this kind of like square on the top, I think on the bottom left of your task, that will just like flicker according to what the patient is doing. And so you will have to, look at all this flickering, and that this is because the patient is doing something. So you also have to align all these different systems to make sure that you can look at, the data across patients. And then, of course, this eternal question of epilepsy and brain plasticity, which is something each time you want to publish and submit a paper, you already know that a reviewer will ask you that, so you already have this limitation paragraph that we all have, and we will all write the same thing over and over again. I don't have the answer. The only thing I can tell you is, from my perspective, what we do is, if several patients with similar implantation, like electrode in the same part of the brain, have similar pattern of activity, and you know that these brain regions are like free of epileptic activity, then at some point you start to might think that it's actually true. But it's, yeah, it's, so far this is all I can tell, but yeah, it's a good question, to be honest. So I understand why the reviewer asked it, but you know. And I don't know how, like, time-wise. Okay, thanks. So, and yeah, I just wanted to finish about, like, to talk to you about the next challenges in IEG, because of course it's also evolving, and now we're using IEG differently. And so the first thing that's become really trendy is single neuron recordings. So it's a really hot topic, and it's really interesting, and really, I mean, I don't know if you understood so far, but when you have this SEEG and IEG data, and I think Stephanie mentioned that, like, you have so many things that you can do with that. You have this huge, beautiful spatial resolution, temporal resolution, and actually we ended up doing like some bigger blobs because it's already too hard that we kind of like already go in a upper, like higher level than, you know, the one we have. But some people want to go even like more deeper, and now we have single neuron recordings. So this is only for clinics. This is only for research, sorry. So like the clinicians don't really use that. So it's mainly for researcher. And so what happens is at the tip of your SEEG electrodes, you will have some microwires. And sometimes also you can have them like even in between contacts, but it's more rare. And this microwire will record one single neuron to increase the number of data you can have. And so that now people use these things to do some spike sorting. So they will just like try to find some patterns and like, you know, coherence between neurons and like see, you know, which neuron is doing what and things like that. So we start to have like a couple of data like that. And to be honest with you, I'm avoiding it as much as I can because first of all, I don't have any hypothesis at the neuron level yet, maybe one day. But so I think, yeah, so far I will stick with my SEEG ones. I think it's enough for me. But actually, it's not exactly true because this is what I'm doing right now. I'm doing dual IEG. Yeah, so hyperscanning inside the brain. And this started because of these guys. So Arjen Stock, Randolph Elfrich, and Colin Hoy. So they were in my lab, and they were recording at Irvine a couple of years ago. And they saw that when they arrived, 2 patients with electrode inside the brain were actually, you know, getting implanted at the same time, and they were next door. And so they found that's so nice. So they went to Home Depot, like Monsieur Bricolage, and they went to buy a bunch of cords, and they decided to just plug them together. And it was pretty cool, to be honest, because Arjen is working on this nonverbal communication task, and so we have to work with the patients, right? We're like experimenters, and we have to work with the patients. And so suddenly they try to make that work, really like you know, homemade style. And so based on that, so Bob Knight found it so cool that he decided that we should build a task on that. And so he asked me to work on that with Atina Tsovara. And we were like, yeah, that sounds like a good idea. So we come up with this idea of this inter-individual communication. So we started to, like, I think the main point was, what are we doing when we try to communicate, you know, between each other? That's easy questions to answer. And so we saw that when you are speaking, like as I am now, I have this idea of what I want to convey, right? And so then I will use my word and everything to, you know, to try to guide you through having the same kind of ideas as me. And so this kind of like transfer of representation based probably on prediction. And so we try to come up with a task to, you know, show that. But remember, we are like in a hospital settings, right? So you can't let patients speaking to each other. It's unethical. You have to find ways for them to communicate, even though they can't see each other and they can't really interact, you know, like in a normal way. This is a task we actually end up using. So you have a sender. So these are like the two screens. So one patient will see this screen and the other patient will see this one, and they will be sender and receiver alternatively, right? And so the sender will see one item, either an animal or tool, and the receiver will see two, an animal and a tool, right? And actually what we ask the sender to do is to fill out this axis according to what he thinks, this item is doing. And I don't know if you noticed, but, and here there is a mistake, but for instance, yeah. For the receiver, you can see that, he has these two options because you will have to choose between the two. But as you can see for the sender, it doesn't see what the other item is because I don't want him to do the comparison between, the two objects. I want him to describe how he thinks the flamingo is. And so we use 4 different axes. We use, does it make noise or is it like kind of mute? Is it big or small? Softness as well, and also if it's more inside or outside. And so each trials will have these 2 axes that people will have to fill. And we also make different levels of complexity. Sometimes as soon as the sender, fill out one, like the receiver will know which one he's talking about. Sometimes it will be trickier. You will need the second axis to know actually to differentiate between both. And sometimes it will be really hard because the 2 objects will have like similar features. And so and of course then we'll have a feedback. And at this time the sender will see, we have the 2 name and, we'll know what was the other options. And then it will be able to actually, see if they had this successful communication or not. So it's kind of like a guess what. And actually when we piloted the task, that was pretty fun because you adjust the way you communicate, with the person according to the person you're talking to. And so I did the task several times, but I never used exactly the same axis and the same way because I work with different, I was doing it with different people. And that's also why we wanted axis and not only these 0-1 options. We wanted them to like have this flexibility of changing the way they were seeing a flamingo throughout the task according to the people they were working with. For instance, I have a colleague for whom all animals are soft. And so then once you understood that, it makes your life easier. As soon as you have an animal to like, make him guess, you will just like put it all the way to soft, even though for you it's not. So you adjust the way you communicate, based on who you actually communicate with. And well, this is how actually it works in practice. And so we already recorded studios in California. And, sometimes the doors are not adjacent and the patients are not, close by. So you have to find ways to make it work. So yeah, we flew all the way to San Diego with like bags full of cords and screens and of course duct tape. This is becoming my best friend. And, just like to make sure that we won't bother nurse and everyone with all of our cord and things like that. But yeah, it's pretty fun to do. And actually patients love doing the task because they know that they're doing it with someone else who is actually undergoing the same surgery as them. So it's something like, it's pretty cool. And the last thing that I wanted to talk to you about is this at-home device, this responsive neurostimulation, which becomes also really trendy. And they will just like put this neuropace, like this stimulator in the brain, and they will try to prevent epileptic seizures at home. So patients will have electrodes inside the brain. They will like be monitored, and then, they will try to prevent seizures like that. And actually it's becoming more and more popular. So we have more and more patients with this. So this is kind of like the new things that we're starting to dig into it, because also if we can do this communication with patients at home, it will be pretty cool. I think that's all for me. So I also wanted to thank all of my collaborators in my main 3 countries I lived in. And so this is, people I did my PhD with, and I'm still, like in touch with them and still working with them. All of my team in Norway, and of course my team in Berkeley and in other part of the US. And of course, I also wanted to thank the patients because none of this will happen without them. And thank you for your attention.
Thank you very much. Do you have any questions? Well, is there actually one?
Okay, thank you very much, Anais. Very nice talk. Thank you for showing also Anne-Sophie's work, and I want to take a little time before the question to pay a tribute to Anne-Sophie. Maybe she's here. So not only because of the organization, co-organization of this wonderful conference, but also because she was involved in one of the most challenging setups ever, which is EEG, MEG, and intracerebral EEG at the same time. And we needed her skills and courage to do that. Bravo, Anne-Sophie. So now to a question that probably you've had many times. So now you've seen the two worlds of SEEG and ECOG, which, by the way, Canada is very important in ECOG.
Canada,
we have to mention Penfield and Jasper. So what's your feeling? I mean, there's been this fight for many years between the North American and the French-Italian school.
Yeah.
So in terms of research, what's your feeling of the differences, of the pros and cons of the two?
Yeah, thank you. Yeah, it's a really interesting question. Well, actually, the thing is, I'm really biased because I've been raised and fed with SEG. So this was my main school of, study and things like that. And I kind of like SEG for these depth structures type of things because, I'm working mostly in memory and language. So hippocampus is kind of like one of my, region of interest. And so having access to the hippocampus directly is actually pretty amazing. And that's also now I'm actually starting to look into the insula. And also the same thing, like being in SEG is also really helping for that. But it's also really frustrating, this sampling, the fact that sometimes you have like 1 or 2 contacts in the hippocampus and it sounds really promising, but then you don't have the rest of the hippocampus, so you don't know if the tail is doing the same thing at the head. And sometimes it can be also frustrating for that. But then with the ECOG, it's really nice if you want to look at the flow of activity, because you will have this kind of like beautiful spread out of activity that you can see in like speech and things like that. But you still, I think somehow you go back to this issue of being at the surface of the brain. So still you will have this beautiful spread out, but you will not exactly sure of where it's from. So it's kind of like depend on your research question. One might be more adapted than the other. And practically also, ECOG patients tend to be more tired than the SEG one because the surgery is way heavier than the SEG. And so also practically it's harder to do tasks with them because they will be really tired. And so also that's also why there is this shift now in practice, because it's less heavy for patients. So yeah.
And you mentioned the microwires, which is cool, but probably very difficult to acquire, I guess.
And it's really heavy also in data. Like,
and maybe some people are trying to use it as LFP, also micro LFP.
Yeah.
So do you have experience
No,
on that?
I do not. Yeah, I do not.
Maybe that's one way to use it.
Probably, yeah. So far, it's like what I saw the most with this single neuron things. I like the spike sorting and things like that. And I think so far they're already at that. They're still at that stage because it's really complicated actually. But it seems to be pretty promising. I have like many friends working on that. But it's also, I don't know. I feel like we haven't resolved exactly how to look at SEG data or ECOG data yet. And so, of course, science is going really fast, but I feel like I haven't exactly explored everything I can do with this data. And so, kind of like increasing the amount of data, for me, it's really overwhelming, but it sounds also really cool, yeah.
So I was wondering, how do you see the future of, both SEEG and ECOG? This is against the background of a conversation I had with neurosurgeon Brian Litz quite a few years ago, who said, this whole epilepsy surgery is kind of medieval. We're cutting out parts of the brain. We're putting electrodes in the brain. And slowly, of course, our methods for brain imaging are improving.
Yeah.
So how long will we still need to implant electrodes? And, at some point, it's probably going to be hopefully obsolete. So what do you think? Although it's very sad, of course, from a scientific perspective.
But I understand.
Yeah.
No, it's a really good question. Thank you for that. Actually, I can already see how the techniques are already even evolving right now. For instance, before this stereotaxic, frame, and, it was like always in SEG and it was really heavy. And I remember we're shaving patients' head. It was a lot. And now it's, most of the patients can keep their hair. And you have this kind of like MR, assisted type of surgery. And so it seems to be it's still invasive. The end, the goal is still the same, but the practice seems to be a bit lighter. And so it's already evolving, but yeah, it's still really medieval. But so far, I think, as long as we haven't found drugs for all type of epilepsy, the surgery is, I think, the best solution. And actually, the balance of benefits risk is, it's like 70-30 or something like that. It's really high. Like most of the patients, if they don't end up being free of seizure, what we call them when they have one full year without seizure, their life quality will improve most of the time, for sure. Yeah. So, but it's definitely a really weird things to go through, and that's why when you arrive in a patient's bedroom, it's something to remember. It's like it's hard for them, and they do that. If they are volunteer to do something, once they just had a really like heavy surgery, and their kind of future is at stake because they're waiting to know if they will have a surgery or not. It's also a lot of psychology, to get in and to like work with them. We have to remember that.
Any other question? Okay, if not, we can thank again you for your presentation. So now we can switch to the general discussion altogether.
We're in the process of inviting Sarah back.
Hello, and okay, so we can start the discussion. Are there some questions now to any of the speakers or all of them at the same time?
Or perhaps
Don't be
from
shy.
the online chat. I don't know if are there any questions from the online chat?
I love CuttingEEG DJs. That's good.
Yes.
So this is a question for all of the speakers, because you're all doing really cool stuff, but at the same time, it's because I guess it's so cutting edge. It's very few people in the world doing this kind of research. And is there a way that we can, scale this up or collaborate so that we can enlarge and generalize our data set? So I guess now it's becoming more and more evident that to do good research, we really need often more data than we are frequently collecting. So are there ways that you can share your method so other people can also use it and collaborate? So what do you think about that?
Hello. Yeah, well, definitely. So the first, I don't know if is Sarah here. Yeah. Seeing and talking to a lot of people at this conference, seeing what some of the limitations of some of the current techniques that we use, and seeing where we can fill in those gaps with these new tools. So I think, at least in my perspective, what we're working on with the more, so the wearable MEG can really maybe complement what we have. So start to work together with those with EEG and other techniques, FNES, that where there is a lot of data that is missing in MEG, for example. There is definitely there has to be conversations of and I've already sort of asked if to get input of what things we need to consider if we are changing. So the technology is changing constantly, but what things do we have to take into account if we're going to then start exploring like different subject groups or different types of experiments?
Yeah, and no, I agree, and I do think that we are starting to work toward that, now more than ever, which is great because, yeah, having enough SEG data or IEG data to do a study takes, ages, and because you need not only to have patients, for instance, like the 11 I showed you, I actually have 25 patients who did that task, but I'm only looking at the patient with a similar implantation because, like now I'm focusing on phototemporal network, for instance. So I'm only looking at patients with this type of implantation. And yeah, it's really challenging, but I think, for instance, where I am now at Berkeley, I'm really lucky because I have 5 hospitals or 7 hospitals working with us. But when I was in Oslo or in Marseille, it wasn't like that. And I think during my PhD, for his PhD, I think I recorded 60 patients, which is a lot. And actually my data are still are used right now, which is pretty cool. But we are starting to talk more about sharing data, having kind of hubs to do that. But sometimes it's really challenging too, because if you work between countries and if you do, for instance, linguistic task, it's really tricky because, for instance, I have my task that I'm doing now, for instance, in prediction in language. I have an English version and a Norwegian version. But then I can't use exactly the same parameters. The task, it's not the same phrase or anything, the sentences. So it's also really challenging, but I think we're starting to discuss more about this kind of sharing. And I do think it's the direction that we need to take. Also because the technique is so challenging that I think we also need to share more how we do what we're doing, because we can't do everything by ourselves. And I think, people are maybe good in connectivity, and so we should just talk more about these things and, things about science first. And yeah, I think it's a really great comment.
Yeah, can you hear me?
Yes.
Yes.
Well.
Okay. Yeah. I agree with everything that was said, and also I would say in developmental research, there's increasing interest in, of course, in using larger data sets and collaborating across labs. There's, for instance, the Many Babies project, which is trying to get similar experiments to run in labs across the world to replicate findings, also using EEG. And I think that's super important. And I think there's also an increasing availability of data sets, openly available data sets, which I think is really important. And I think especially if you want to look at longitudinal data, it gets more and more difficult and more, it takes more and more time to actually get large enough data sets. And I think that's also a point where large scale collaborations is really important.
And I have a small comment on that also, is the legal aspects of it. I'm a bit struggling right now with that. So we have great work in the team, including by Aude Jegou, who's here, on putting the data into bids. I see there's a bids comment by Guillaumard, and we really like this data structure. But now we have to convince the hospital that we need to put it for the whole world. And we will hopefully do it, but we see that it's not yet completely smooth. But we have the European rules, we have the French rules, CNIL, and we have to overcome them, because one difficulty is that data may never be completely anonymized. You can always claim that someone can find somebody. So we have to overcome that. So there's the technical part of the bids, and then there's the legal part.
So this morning you've shown really cool and exciting, but also very challenging techniques that are used for neuroscience. A lot of us are working in an academic environment where training is also part of our work. Like PhD students have to learn all these methods while they're doing the research, or have to do research while they're learning new methods. There are certain research methods that are safer because you just know that they're going to work. And the methods that you've been presenting this morning, I would say that they don't fall in that category. Like, they might not work. So could I get your opinion or your reflections on how does the risk of doing this type of research, how does that reflect in career choices of a PhD student or a postdoc?
Well, that's a really good point. So for instance, in SEEG, in IEG world, what we usually do is we conduct EEG study also in parallel. So we have a lot of like EEG data. We have EEG, labs. In each lab I've been working on, in IEG, I always do EEG as well, sometimes with a patient with stroke or resection and things like that. But we always have like some EEG data to work on it because it's way faster than to wait for having patients. But it's actually a really interesting point also, like career-wise, because for instance, I can see that on my resume, I have less paper than some of my colleagues who only do EEG because I need much more time to do what I'm doing. And that's also something that it's hard to show when you just send your resume for like in a job market and like, I'm actually working a lot, but you can't see it because I'm publishing less because I spend my days in a hospital waiting for a patient to want to do a task. And, that's also really tricky when you do this type of kind of like cutting edge techniques. Yeah, for sure.
Yeah, that is that's a really good point. We always, we always have to sort of compare what we're doing. We're constantly, at least so in our lab, try new things, and obviously it's still prototype stages, so it doesn't really work as well. Also, I think at least in the research environment, I don't know about everyone, but at least we end up scanning ourselves a lot. So you get the best subjects you could ever get for MEG. I think I can move just a millimeter in a conventional MEG if I really try to, because I know what I'm doing. It's gonna help my colleague to get the nice data that they want. But when you bring external people, and we had this with now PhD students whose project depend on a larger study of, I don't know, MTBI patients, and they have to scan external people, then things start to go wrong because we're not used to. So we've been doing the training in the lab with us, so there is not that translation to the real world really. So yeah, but then in terms of data, we also we cannot just we always need to compare it with what's sort of the gold standard, I guess. So it's always relieving for PhD students to give them some like proofed and tested data set that they can play with and say, well, this is what it should look like. You will get there eventually, but yeah, it's a slow process.
I would say,
sorry.
So for my field, I would say it really depends a bit on the context also which you're moving. So if you're looking in a developmental psychology context, kind of everyone's in the same boat. So there, I completely agree that with the two other speakers that I probably like publication-wise or how fast you can conduct studies is slower compared to when you work with students. But if you just compare yourself in a way to other developmental psychologists, everyone has these issues. And one thing, for instance, that I notice when I compare like people working in developmental psychology to like the more neuroscience people is that also the kind of the time it takes to publish and then to get cited and stuff like that just is everything slower. Then it also recruitment and how fast you can run studies very much depends on the context where you're working at. So when I was doing my postdoc at the Max Planck Institute, it was super easy to run studies because they had a really well-funded, great infrastructure of recruiting participants. Babies, there are always babies somewhere. You just have to recruit them and get them to the lab. And there it wasn't a huge problem running a study in like 2 months or so. Now that I moved to Lübeck, where I had to kind of set all that up myself, it takes a lot longer. So if you have a great infrastructure, doing EEG with babies is completely doable in a reasonable time, but it takes a lot more effort and support and planning to get that all running. And with respect to like PhD students or final year students, what I would typically trying to do is to combine like more explorative aspects with more well-established parts that I'm pretty optimistic would work out. So they have something to fall back on that I'm more optimistic will work compared to the more explorative stuff.
Can I just follow up on that same question? But would you have any advice for the PhD students in this room who are doing cutting edge methods and who are maybe a bit stressed about, sorry, I'm here, who are stressed about how they're going to be able to finish their PhD given the setup? Just for those who are here. So it feels like you said that it is complicated and it can be slow.
Sorry, I but were you referring to something specifically that?
No, well, about the type, just a follow-up question on that same question Robert was asking, for this type of data, given that it can be really complicated to acquire the knowledge of analysis, of setting up an experiment, of collecting the data.
There is, I mean, it's not all down to, we cannot just bring a PhD student and it's like, there you go, you're on your own, just try and switch the thing on and then collect the data. So there is, because there's still lots of things that we haven't done yet, and it's our responsibility to, at least with these sort of cutting edge in continuous like development, we need to sort of put a stop somewhere. It's like, okay, we're gonna freeze the system as it is now, and develop the tools that are, and give the proper training to start with, to not just let them waste months in just trying to learn by themselves, and then in parallel you can carry on with other developmental stuff that more like maybe second or third year PhD students, that they've already had the initial briefing, I guess, so they can then fiddle with new and exciting, I don't know, different projects. But yeah, I would suggest, I don't know, this always is not down to just one, like the PhD student side of things. There has to be, just go to your PI, to your supervisor. If you're lost, just say it. I know the PhDs, it is yours, it's your experience, it's gonna be, you have probably a goal in mind in 3-4 years that you want to achieve something great. It is a very long journey, and if you start with something that we've never really seen before, is really like niche, and maybe 5 people know about it, well, go and bother those people. Don't waste time just trying to figure it out by yourself. There are tools there, but it's just, we need to sort of try and put them together, and slowly making it easier for new PhD students.
Thank you.
Sorry. Okay, yeah, sorry. Yeah, actually, I've been there. I did SEG during my PhD, right? So I even studied during my master degree. But so what I did is, my first paper of PhD is actually a review. I reviewed IEG paper using the same, cognitive models as me. And so it was my first paper, so it was not even on my data. Actually, my first SEG paper as first author came out after my PhD. And I did an EEG study in the meantime to have something. And then I was second author in the IEG paper with a postdoc as first author. So I kind of like, piggyback on someone else. And now I'm like 6 years after, and, my PhD data are still in use. So I'm still like, I have my name on paper now. So it's kind of like, it's still paying off now, but it's absolutely tricky. But the thing is, yeah, you have to find your community. It's like, I know many people in the world, working on my field. So then I feel less isolated too. And I really agree on the fact that it's something you need to discuss with your PI as like strategy. So what can you do once, while you're waiting for all this data? Because sometimes, I don't choose when I have a patient or not. So I'm really dependent on that. I can't make it faster. And so, yeah, you have to discuss having this kind of like short-term strategy to make sure that you have something in your resume. That's why this year actually I had time to do a gender-biased paper because I'm waiting on my data, right? And it was the pandemic. I didn't have any patients, so I developed something else. And so, yeah, it's you need to be really flexible, and it can be really challenging. But it's also, I think, exciting. Like, I can speak on my name, and I'm pretty sure it's the same for all of us. It's also really exciting to be on this kind of like cutting edge type of things. That's also this benefits of like doing something that not a lot of people do.
I would add also that hopefully reviewers can accept much less data if you are really at the cutting edge. I mean, the case study, so I would advise to try to go for 1 or 2 cases and really take the most of this data. And then the reviewer should know, if it's a good reviewer, should know that how difficult it was to get this data and let it go. Yeah.
Another important thing, I think, with respect to actually like finishing your PhD at some point is to also know when to stop trying out new things, which I think is something many like PhD students have to learn, because there are so many cool stuff that you could do with your data and it is super interesting. But you can also still do that after you get your PhD and continue working on the data set. But I think there's a certain risk, at least for like the really motivated PhD students who are really into trying out different approaches and different methods, to kind of get lost in trying out this and that analysis, and then ending up not finishing the manuscript or the paper, or actually that they need to finish their PhD. And I think it's, like, especially as a supervisor, important to also like learn that together with the students, like what needs to be done to finish the PhD and what could also be done afterwards in the data set in a more explorative way.
Yeah, just one word actually according to the experimental part, because it's not really well recognized in my opinion. Sometimes it's just 2 lines in the methods, and it's a shame in my opinion. For instance, when you're performing like longitudinal analysis, you have to welcome many people for several times, so you have to also have a lot of interactions with these participants and or patients, depending on the protocol. And sometimes it actually doesn't appear in the paper. And such interactions with people is strongly important to create so trust between you and the participants about the aim of the protocol, of course, and to be aware of the aim of the protocol. So sometimes it should be nicer to recognize a little more that. And so now perhaps by making a database available, it's a good way to recognize a bit the work done by people, but perhaps we should also mention that. And about the guidelines also, because you can see a strong variability between teams and labs about the way to perform experiments in EEG or MEG, for instance. So, for instance, the BEATS initiative, it's a good one to have in mind for guidelines to perform experiments. And for PhD students, it's a good way and good resource to study at the beginning of your protocol, in my opinion. Any other question?
I will just advertise a bit that there's a European initiative to share data. Yeah. So hopefully that can help if you don't have data, then you can get to the shared data. It's called the HIP, and it's trying to gather data from many centers, intracerebral data from many centers. It's Olivier David, Philippe Rivelin are leading that. So hopefully more and more initiatives like that will be done to help the people, yeah.
So I have the microphone, so I'll speak. So one follow-up comment, and along the lines that you just mentioned, in every lab that does this kind of EEG has lots of data from previous experiments. And I think for the PhD students, the best thing to do is to start by looking at data, existing data. This is a gold mine, right? That there's so much to do with this data. This is such precious data. We got it from the patients, we got it from kids with a lot of effort. And what happens is one PhD does this study and gets the information, and then the study gets stashed in on some computer. And I think that's the way to go. You first learn how to do this kind of analysis. You realize what are the pitfalls. You will get a paper out of it probably if you do the right things. And that's I think really important to realize. And I wanted to actually ask a new question, which is, what do you do with pulling across subjects, especially in ECOG and IEEG, where we have a sparse sampling of the cortex, and we try to bring the subjects together, but we're losing on the statistical generalizability of the study because we're actually making it a fixed effect study instead of a random effect study. So what are your opinions on how we can, what's the right way of combining data from different subjects?
Yeah, thank you. Yeah, it's a great question. It's actually something we discuss a lot. I think in many labs, it's like each time you have a study and you arrive with like all these beautiful patients and you can see similar things across patients, and now you're like, okay, so now how I'm going to show that this is real and it's not for only one patient. And it's actually, I don't have a real answer because we're still like struggling, and I think it's like it depends on the analysis you're doing. And then, but it's a real question. Like now, for instance, I'm working on that right now, and yeah, you have to take into account that are not patients, so you can't just like pull them and like pretend that it's one brain, and like you can't do the same thing as in EEG where they're all together, and you can't do that. So you have to take into account the specificity of each patient. You can't do anything else, and it's a good question. It's really complicated. And yeah, I don't have a good answer. I don't know if you do, but
no, there's none, and it's very difficult not to lose the patient specificity. You're so exquisitely specific in intracerebral EEG, and then when you go to the MNI, just don't lose this precision by just having a big blob. And also patient, the implantation can be different, although you said that hopefully sometimes it can be more standardized. So just shifting a few millimeters could lead to very different results of brain activation. So it's not solved. I guess you need a lot of data, and also to focus on the few regions where you have enough sampling from the clinics, and this you have no control over it. The hip came. Thank you. So are there other questions?
Yes, thank you. I have a question to Anais, if I may. So I'm trying now to work with EEG data. I have a lot, and I have these problems which you just mentioned, that how to homogenize this data, how to make decisions about localization, and so on and so forth. And I don't know, I know that people make these decisions somehow, but they never write it in method section. And I don't know, what should I do? How should I learn to do this? I mean, I'm starting my, it actually has been already a few years. I collected lots of data, but I don't know how to analyze them properly. What should I do? It's part of my PhD thesis, but I need to finish soon. I'm completely lost. Could you please advise me something?
No pressure. Welcome to my world. Actually, this, I'm struggling with exactly the same thing, to be honest with you. I thought that I would come with, a study completely fully done, and of course, science happened, and I found something else, and now I'm going somewhere else. It's really hard to not be overwhelmed by the amount of data and the things you can do in CEEG. And I can see many of my colleagues also struggling with what you were mentioning, I think it was Sarah, about when to stop analyzing and actually starting writing, because you can do things over and over again. You can see things differently all the time. What I would advise is, first, do you have the questions you want to answer? Do you have one specific things you want to answer? And is it one specific regions, one thing? So start by something easy. Do I want to see what happened in the LIFG during something? What happened in the hippocampus? One questions.
Yeah, I've got them. The problem is that I have really technical questions, solutions, how to, I don't know, average across electrodes, across patients, across locations, and such things. Yeah. And so I don't know,
well, now on the spot, it's hard to know, without the data. But I think it's also exactly why we need to share our knowledge and why we need to be more transparent about how all these things are done, and to help people and to be sure that we do the things the right way. And because it's really hard to know. I spent months in my PhD just looking at ERPs in all contacts of my 25 patients. And I didn't know what to do. So I really understand, but it's we can discuss afterwards if you want. We can, of course. We have to start somewhere, so let's do that now.
Once Anne-Sophie has recovered, she can show you the MIA toolbox she designed to try to tackle some of these problems. And also, again, I want to emphasize the spatial issue, that you really need to know where you are in the brain when you put all your contacts together. So you don't want to end up in a different region in the standard space. You really want to preserve the specificity and then try to do your best.
That's true. Yeah, you do have some tools like MIA by Anne-Sophie, also like the one we're using, like the INCS field trip toolbox and things like that. Like just this kind of like walk through once you have the data, what you're supposed to do with that. And also same thing, like talk to people in your team and things like that, because even though they might not say it, they've all been through the same thing as you.
I have a question too, also related to all of that. So when using cutting edge methods, we have like like a lot of outliers, to say somehow, especially on EEG. For example, you have 10 patients measuring the hippocampus, and you have 5 that works well, something similar, and the other 5 no. But you are in the same region, the anatomy is kind of similar. So what shall we do with the other 5? We say, no, these are outliers. I don't like them. Or so when you don't have a real reason to exclude them, because if you have a lot of spikes, you can say, okay, this is epileptic hippocampus. But if not, if you don't have a reason, a good reason to exclude them, what shall we do in that case?
Well, that's the beauty of brain, right? For instance, the paper I published in a hippocampus, I have nine patients with hippocampus contacts, and 6 of them were showing the same thing and 3 didn't. And I just reported it, saying, I have 6 with and 3 without. I don't know why, but it's the way it is. But the 6 with, they show really nice things. And maybe it's not something that you can generalize, through the entire population, but at least 2/3 of it. It's just, you can't hide data. You go with what you have. And yeah, it's hard, but, also you have a lot of plasticity in the brain. And don't forget that these patients, they have epilepsy. So a lot of reorganization happens. It's really hard to know. So you can also explain that in the discussion, being like, I don't know what happened with the 5 others. I might still try to collect more data and understand what's going on, what's the difference. But these are like my hypotheses of why it's different. But yeah, I will go for something like that.
I have a question for the non-invasive part. So now we define, I love CG. Try to link with the other speakers that, you see exactly what's happening in a region. Where can we get now with the new MEG sensors in terms of, so you mentioned a frequency, for example, but you mentioned maybe the sampling frequency, not necessarily the usable bandwidth. And what about spatial sampling also? Can we compensate the lack of sampling in EEG with some MEG sensors?
Well, in principle, by getting closer, you can get also deeper. There has been some evidence that you can measure hippocampal activity with OPMs. Probably not, but still non-invasive. But I don't know if putting a OPM inside a mouth, it's invasive. But but as they are getting smaller, maybe you can start putting them in other areas, like I don't know, maybe inside the ear, or just getting as close as possible to the brain. So in principle, you can get deeper than with conventional MEG. And also, I think one of the things I showed, I don't know if you remember, those patchy coverage that you get when you're getting really closer. So if you could pack, so having a high density array of sensors. And I think this is something that has been taken forward at NIH. They sort of want to kind of maybe replicate what you see with ECOG, like at a very surface of the brain, having lots of these sensors right on the scalp, can you get something that it's equivalent to it? But yeah, in a way, you're limited to the bandwidth, and the high frequency, you might not get those, but at least sensitivity by getting much closer, it's possible.
The trick in the mouth is very interesting, to have a view from underneath for the spatial sampling. How difficult is that?
Well, this is all Gareth Barnes.
That's Gareth's crazy idea.
Yeah, crazy idea that and he was the subject, obviously. Yeah, it's just, I think so. They modeled the fields, magnetic fields coming from the hippocampus, and they found that actually the most sensitive area would be at the top of the mouth. So, and they did it, and it seemed like they got some results and theta signals from the hippocampus. So nothing is impossible, apparently. So.
Actually, it's quite linked with the OPMs, because we hope to have very less bulky system in comparison with what we have now. But what about the possibility, because we can't get rid of the magnetic shielding rooms, so can we hope someday in the next future to have a reduction of dimension of this room for BCI application, for instance, or even for monitoring patients at home?
I want to say yes. I'm not, and the timeline maybe, I don't know, when I retire, I don't know. There are, so as the OPM field is really diverse, so there are groups looking to just make the sensor smaller, but compromising a bit of sensitivity. There are others trying to improve the bandwidth, so getting more frequency signals. And there are some efforts to make them work in unshielded environments, so working in earth field. And it's already been shown in Princeton, I think, yeah. Well, they've managed to measure some, I think there were auditory evokes, I think, in the middle of a field, completely outside. So it is happening. It's being developed. So, but that's very challenging. If what the fields that we're measuring, is, at the moment I can see it happening, in the quietest environment somewhere in a field. But it is happening, so I don't see that as a crazy idea. It might become a reality.
To close the loop, maybe we need to say what I know Marie-Constance wanted to say, that the babies should have OPMs. I can use them. I don't know if you're ready to put another cutting edge, Sarah.
Yeah, well, sounds exciting. No, I think in general, it's like spatial localization is of course in like an issue with babies as well, because we don't like I mean, there are a handful of studies doing fMRI with like awake infants, but that's really like 4 or 5 studies that have been done so far worldwide. So it's not a huge field. And there are templates for infant brains, but typically what we are doing with EEG or also with NIRS, so NIRS is the other method that's commonly used with babies, is limited. And so, any approach to get more like a different angle on spatial localization would of course be super interesting for the future.
Well, I think we're in time now to finish. Yeah, is that okay? So I would like to thank again the speakers. Thank you very much. And we're handing the mics to the organizers. Thanks again.